Hi, everybody. We are in Denver, and as you can notice, we're in the same room, like I can touch Priya. And we're here at ICCMO. This is where we met last year. So for a full year, we've been at it.
I love it. We met at ICCMO in Calgary last year.
Right.
And Dr. Alex brought her whole team, which inspired me to bring my team this time. So, like reminiscing, that's where I met you.
Right.
And we really hit it off. I hit it off with you, your whole team. We went to so many fabulous dinners together. And that's where the whole idea of this podcast came about. So it's so fun to be here again.
It really is. And then we came in yesterday and we went to dinner again because, you know, it's all about food.
Yeah.
And it's so nice to meet her wonderful team. They're
them.
they remind me a lot of my team. They're very in it.
Mm-hmm.
They own neuromuscular. They're passionate about it, just like we are.
Mm-hmm.
And they're great and they got along well. And it's just fun.
Yeah.
And so that's where we came up with doing the podcast last year. We're like, hey, you know, we hit it off. She's the TMJ doc. I'm a TMJ doc on the other side of the country. So we thought that would be neat to have our podcast. And then here we are a year later.
Yeah.
So what are you looking forward to at the conference?
I'm looking forward to seeing Dr. Ben Sutter, listening to him speak, and just, you know, seeing all these people that I consider like mentors and that I really look up to. You, Pam Marsban, Prabhu Raman, just conversing with everyone and having my team really fully understand like the science behind of what we do. Because we're going through all the steps. We're doing it all at my office, but to really understand it fully is why I was really motivated to bring them. So what about you? What are you looking forward to?
Well, I'm looking forward to Prabhu because he's going to go over the CBCT scan and everything to look for. And though I've been doing that for years, it's amazing. Every time I come, there's something I pick up or something that I'm refreshed on. And ICCMO is such a great learning atmosphere, like you said, and it's fun. The people are fun and everybody's kind of on the same page and we think alike. And when you're around like-minded people, it just kind of refuels you and re-energizes you. So I'm really looking for that. I always look forward to Ben Sutter because he and I communicate a lot. I'm participating in a study with him. So hopefully by next year, we're getting some feedback from patients and things like that. So he's going to be doing the writing. I'm just doing the gathering of the info and stuff that's going on with patients. So that's fun.
Yeah.
And we've got Cindy Stein, who does nasal ballooning.
Oh.
That's a different one. Yeah. I've worked with her before in the past, and she takes these they look like finger caught balloons, and you go into the sinus cavity and even a little bit in the way back where the concha are up the nose and stuff, and put some air, and it kind of moves the bones in there and opens up the airway. So that's going to be neat.
Yeah.
I don't think I have the guts to do that in my office.
No, me neither. But I want to learn about it.
Yeah. Right. Because we got to know what else is out there.
Yeah, definitely.
Yeah. So what about questions? You said there were some questions that people were sending in on these. So let's go over a few.
Yeah.
And then a few we're going to save for when we're at the conference. So then we're going to ask other dentists that practice like us to help answer the questions or see what their views are on. It might be a little bit different and might not be.
It might not be. Yeah. We don't know. Yeah.
But it'll be nice. And then you can see other faces from there's people here from Argentina. Oh, I'm getting my fellowship today.
You are?
Or not today, tomorrow. Yeah. So I'm getting my fellowship and some people, I know, like I'm so happy.
Yeah.
So I'm getting my fellowship for ICCMO, so that's a big thing I'm looking forward to. And a lot of people that are getting their fellowship, there's some from Argentina, there's some, they're from all over.
Yeah.
So, which is so nice. I think there's someone from the Philippines. So ICCMO is really worldwide and it might be bigger in some other countries like India and things like that. But we are in the process of building it here.
I love it. Well, so I also brought my team to piggyback off that for us to like formulate how I can get my fellowship too, because it's the gathering of the cases and the presenting of it and submitting all of it. So I'm like, oh, we need to get on that. So
yeah,
I'm super, congratulations.
Well, thank you.
Yeah.
Thank you.
I know it's hard work. Well, let's get to some of these questions. So
okay.
First and foremost, can TMJ cause ear pressure and fullness? Do you want to take it or do you want me to?
Either way.
Okay, I'll start.
Okay.
So ear pressure and fullness, TMJ can definitely be associated with that. When the joints are really compressed up into the joint space, when there's not enough space. So basically when you bite together, there's a certain amount of space inside the joint between the bony components of it. And if there's not enough space, things can push back and compress everything. And what's right behind the joint? The ear, my friends. So that can cause the sensation of ear pressure or fullness, but there's also muscles that surround and support the eustachian tube. Those small ones with the weird names like levator, villi, palatini, and
chordae tympani.
Those little muscles, when they're inflamed, they put pressure on the eustachian tube, which can also cause the sensation of the stuffy ears. So if we can just relieve the muscles, take the pressure off the joint, we typically see that go down. But yes,
take the inflammation down. Exactly. And, but again, there can be other things wrong with the ear. You've got to make sure you don't have like an acoustical neuroma or something like that. So don't always think everything's TMJ. You got to make sure medically there's not a tumor or cyst or something that's causing that pressure. But I see a lot of patients and we relieve the ear pain. You know, a lot of people will say they've got stabbing in their ear, like an ice pick. I mean, imagine feeling that
multiple times a day.
Right. Right. Like, wow. But so it can be TMJ, but we also want to rule out anything medical and not just have our blinders on that everything is TMJ.
Sure. And there's true like eustachian tube dysfunction. Right. It's not TMJ related. And I would say with stuffy ears or that ear fullness sensation, I have like an 80% success rate, where with other symptoms, I have a 90%. So it's not always TMJ.
Right. And we have a very, very high success rate with that too. And with Meniere's disease, we have a great success rate with
the
that.
T-scan?
With the T-scan, but then also the other way. Yep.
Okay.
Yeah.
So next question, let me see. Ooh,
she has to read these because I don't have my readers.
I can barely see them. Let me see. This is an interesting one. Can TMJ issues affect the hip area and walking? I'll let you take that away.
You know, it can, and it has in my office, and we've proved it. And it's even funny too. When you're not balanced in the jaw, you're not balanced in the neck, and then it's almost like a trickle-down effect. Right, your shoulders can be off, your hips can be off. So once we start, 80% of the disharmony starts, it's called descending, starts from your head down. And then a 20% are from the feet up. So we need to take a look at that. And I've done tests in my office with hips being off and making a patient do certain things by walking down the steps and then coming back. And I do a little bit of this and that. And then they walk back up the steps with whatever I've put in their mouth. And then you can see the hips go right on. And she's like, my hips are on. So then that tells me if I balance her bite, that's going to balance her hips. Yeah. And I've had a patient too from New York who always had hip issues. When his bite was off, he's like, Dr. Alex, my hip hurts. And then I'd fix him. By the time he'd be walking down the hall, he's like, yep, all good.
Yeah.
So it can be related for sure. And there are a lot of postural problems that we have to look at. And we'll watch people walk down the hall, or if I send to my PT, I'm like, check the hips, and he'll be checking the hips and he'll check the calves and see how they walk and everything like that. And it's a whole body. It's a whole body. We got to connect the head to the rest of the body. The head is not independent of the rest of the body. So if you're out there and you're wondering that, just be an advocate for yourself and try to find answers.
Try to find answers and look for practitioners that understand this connection. And one thing I've noticed, a picture really put it all into perspective for me. And it was like a light bulb went off, but it showed somebody with class 3 occlusion, which basically means you're like this. Yeah.
Right.
And they typically posture themselves like this, really with their neck far back. Then class 2, which is more of like,
right. The chin's way back.
Chin's way back.
Yeah.
Those people posture themselves like this, forward head posture. Whereas class 1, where the bite is pretty close to ideal, it's like pretty
More
good posture,
correct.
right? And so the bite can have such an influence on your posture that I think they definitely don't teach us that in dental school, and I wish they did, but it's just something that I've been doing TMJ for since 2018. And it's like, it took me looking at that picture to fully connect the dots still. So it's like, I keep learning, but
yeah. And you have to keep learning. And I've been doing it for over 20 years and I'm still learning and there's still new, and you never can stop.
No, you never can. And nobody knows everything. Right.
Right. Right. But we have a good community to lean on, and a good community to,
that's like
we've had the right. And we've had the chiropractors and we have a chiropractor talking at ICCMO on the neck. I think he's tomorrow or something like that. Jeff Schulten.
Yeah.
He's from Canada.
Yeah.
And so that's going to be a good lecture.
Yeah. Yeah. I'm so excited. I'm just excited to see everyone and all the things. Learn so much. Okay. So next question. Oh, this is a good one. Can TMJ be cured, or does it get only manageable? So I think it's asking, can it be fully cured, or is it something you just have to manage for the rest of your life?
Yeah. So in my office, what I would say would be, because I always have patients 10 years out, 9 years out. Now, if something should happen, like a car wreck, or you lose teeth, that will kind of make your bite unbalanced again. Issues might come back, but they can always be treated again.
Yeah.
But most of my patients, if not all of my patients, I'm like, they're pretty darn good. But if you go and get your TMJ corrected and then say you go and get braces, your bite's going to misalign. So the first thing is you got to think, what changed? I've been good for 8 years. What has changed? And then it could be a car wreck. It could be some kind of trauma, but you can always get back to those good days.
Yeah.
Just like when you have a hip replacement, does that last your whole life? No.
Nothing lasts forever.
Right. But are you going to live a better life?
Much better.
Absolutely.
Yeah.
And I say yes, but in the medical community and the dental community, sometimes they're like, oh, you can't say you cure it.
Yeah.
But whatever.
I think
I can say what I want to say.
I can say what I want. It's my podcast. I love it. I agree with Dr. Alex. I think it can be cured, but we are not stationary people, right? So like if we say it's cured, you're feeling great, and then you get in a horrific car accident where you have a crazy whiplash.
Right.
That makes your neck go out, which can make your jaw go back out.
Correct.
So it can be cured, but you'd have to just sit around in your room and do nothing else for the rest of your life for it to remain stable. Right. Yeah. Stability is like a hard thing because we are always moving, and TMJ can come from so many different parts of the body.
Right.
So that's the tricky part with it. So it can be cured. But checking in with yourself, seeing what changed.
Right.
If you start having symptoms again is something that we have to keep doing forever.
Well, and with our patients too, in our office, I don't know if you do this or not, but in our office, I like to see my patients once a year just to make sure things are stable.
Sure.
Because sometimes too, if you're in an appliance to create your stability long-term, that appliance will wear and it will need replaced, and everybody's at a different rate, but plastic will not last forever.
No.
So don't be naive enough to think that. So we like to keep a check on our patients, and it's just a little quick check. How you doing? Clean the appliance, take a look, talk to the patient, go over signs and symptoms or what have you, and give them the go ahead. But plastic won't last forever.
It won't, and especially with the forces that it's being that it's encountering every night in your mouth when you're clenching and grinding, right?
Well, and when you're eating,
yeah.
Right. And when you swallow, your teeth come together. So you're always touching that plastic, or your teeth should come together, but that's a different podcast.
I know. That's a different podcast, girl. Okay. So let me see. I had another good one. Ooh, what types of TMJ cases do you not treat? So I was going to say a case where I won't treat is when they come with an MRI and it shows that the disc inside the jaw joint is actually like torn. It's torn in half. They can barely open their mouths. Their teeth aren't coming together. I just say it's best to at least meet with an oral surgeon first to see what they can do. Because when that disc is torn, I cannot make it go back in alignment. It's torn in 2 pieces. So that's one thing where I like really shy away from it because I just don't know how much I can help them. I could potentially bring their pain down, but I can't repair that disc, right? So I always say, look at all your options first. And then once you meet with the surgeon, if you do any treatment with them, but you're still having pain afterwards, come back to me. So then I'll treat them. But once it's like torn in half, I'm kind of like, I don't want to be the first person you see because I can't repair that disc. But that's kind of one. And then if someone is really rude or disagreeable to my staff, I don't have any tolerance for that.
No.
I'm like, nope, we're not doing this.
Right.
You can go somewhere else. So those are the cases that I say no.
Okay. I say no to, and not a whole lot. But I do say no to somebody that won't let me drive the bus. Like if they go to other practitioners and want me to treat them, but then want to go here, here, and here. Like I'm the bus driver. I'll tell you when to go to a PT or to go to myofunctional therapy or to go to a chiropractor or whatever. If you don't let me drive the bus, it's not going to work.
Yeah, and it's not a control thing. It's like
maybe a little control.
Well, a little bit, but it's also like they need a quarterback, right? So for example, I had a patient where I had mentioned an upper cervical chiropractor, and then in between the appointment where I gathered all her records and when we gave her the orthotic, she went and saw that chiropractor multiple times without telling me. So by the time we delivered the orthotic, it was so off because she had changed, right?
Right.
So I was like, what happened here? Because it took me forever to deliver it. And then it all came out. And I was like, I really wish you hadn't done that without talking to me.
Right.
So it can really mess up treatment for the patient. So it's not really about us.
Right.
It's more like this, you did yourself no favors, right? So that kind of thing. Yeah, I agree. It's like there needs to be a quarterback or someone driving the bus.
And then with the personality, if it's just like, we're not going to work together because of either the way they are talking to us. We just had someone in the office last week that was pretty much belligerent.
Yeah.
Like, and I want to treat you like, didn't your mom ever tell you kill them with kindness?
Yeah, yeah.
You attract more bees with honey. But it was not, that wasn't happening. So we didn't, we're not going to treat him. And it is private practice. So you can select who you want to treat and you don't want to treat. So that's what I like. We do have a little bit of a cushion there to kind of go on. But the other thing you said about the torn discs,
how you feel? Yeah.
Still kind of would tackle it.
You would?
Sure.
But giving them the expectation that we're not going to repair the disc. Okay.
Sure.
Okay.
But
tell me more.
if the disc isn't torn completely, when you make that space, if it's all the way up here and it's rubbing and torn,
like perforated, like it has a hole. I'll treat those.
Perforated,
yeah.
And if it's not torn completely, we're going to help that for sure.
Oh yeah, I've helped that. But what about torn completely? Would you still tackle it?
I don't know. I had a patient. That had her condyles cut off because so she was in an accident. She fell asleep in a raft in the pool, and then she went over. It was an infinity pool. She went over and dropped 13 feet. Young girl. She was like 15. And her jaw went all the way up into her skull. And she was in another country, and they had to, get a private jet and nurse and this and that to bring her back. And the only thing they could do was, because they couldn't pull the condyles out of the jaw, so they had to cut them off.
Wow.
So there was no disc. There's nothing.
The structure is
nothing
even there.
So we balanced her. We got rid of her headaches. We got rid of her pain.
Nice.
I know. And then we restored her in hard porcelain. So then her jaw stays in that position.
Nice.
So she has no condyles. So she has no disc, but nobody else who was going to help her. And they didn't want to put artificial joint in there because that typically isn't good.
No, it's not.
So yeah, like
amazing. I've never seen a case like that. That's really cool.
Yeah, that
you
is
could help her.
Yeah, that was the worst case I think I've ever seen.
Wow. Okay. Well, yeah. I mean,
and then we've had a case too. A patient just had one condyle cut off, And we've had other post-surgery because surgery, I was
I've seen post-surgery.
It's crazy.
And I have a patient in treatment right now who I cannot for the life of me figure out why she got surgery. She was recommended jaw surgery, so she did it. But now she's in like a world of pain. And I'm like,
wow.
And even a surgeon that I've consulted with was like, why did she get this? I was like, she shouldn't have. And so we're getting her out of pain. She's feeling a lot better, but poor thing. I mean, she's just the sweetest.
Going through a lot.
And she's compliant. Someone told her to get surgery. She got surgery. I'm like, no.
Right. So that's another thing too. To surgeons, everything looks like surgery. Mm-hmm. But get a couple opinions. Just
please get a couple opinions.
Don't trust somebody.
What about the fascia? What about the muscles after that?
That's surgery? another lecture is the fascia. That'll be good here to come.
Oh yeah, it is.
Yeah.
That'll be a good one. Okay, sorry, we've spent a lot of time on this question. Let's go on to another one. How do you treat kids under 12 with jaw pain?
Okay, so the way I treat kids under 12 with jaw pain is sometimes, first we've got to gather records. We've got to see what's going on. A lot of the kids with jaw pain are class 2, meaning their jaw is more posterior or pushed back. So they look
and this is not to make
just
fun,
a micro, look like a micro mandible. Yeah. And it's hard to like really do that one.
Yeah, it is hard to. You can get our jaw forward.
But you can't get your jaw back.
Yeah.
Okay, so under 13, sometimes I put stops on teeth, which are little like buttons I kind of attach to the back of the teeth to raise the jaw. So that way it'll release the pressure, because a lot of kids that have pain too have headaches and neck pain. So some maybe physical therapy or myofunctional therapy. Got to look at the tongue. If the tongue's tethered to the floor of the mouth, that's what's causing it. So we got to look at and gather a lot of information before we decide what we're going to do. Sometimes it's an appliance to get some expansion going, open up the airway. And once you do that and move those front teeth out of the way, that lower jaw is going to come forward.
Does it?
Yeah.
It does.
Yeah.
Okay.
Oh, yeah.
Yeah.
I
don't do phase 2, right?
Yeah.
So it's very different. Yeah. Okay. Well, for the kiddos, what I see a lot of is the jaws far back and they're clicking, popping. Some of them are locking. They have headaches. Their jaws like getting stuck where they can barely open, right? And so for them, I do my usual protocol. I do the orthotics, but I'm very careful because they have teeth that are erupting and falling.
Correct.
So I'm checking on those
That's
teeth.
Always changing.
The teeth that are changing. But I've had tremendous success with getting them unlocked and out of pain. But then I'm like, phase 2, they have to get everything in the right place. So I've been on this hunt for the orthodontist of my dreams. And I think I found someone. I found an orthodontist that is familiar with neuromuscular, uses TENS. But I'm learning at this conference, I've already learned, and I haven't even attended a course, that I should be monitoring that patient with the K7 or 10.
Well, I don't monitor my young patients with the K7.
After they're an ortho, you don't? Because that's what I was kind of told to do.
Mm-hmm.
No,
I don't. Okay. I haven't, and I haven't found the need to that. Good. I mean, maybe.
But you do the ortho.
I do.
That's why. It's because you already know, like you're doing the right.
Right. So that can get a little tricky because right now I have a patient who came to my office in orthodontics. Mm-hmm. This is an adult. This is not a child. But I had a child too that came to my office. But anyway, this adult came to my office already in braces, being treated by another practitioner and having headaches and pain. So she comes to see me once a month, and I put pads in there to help her with her headaches and pain. And when you're an ortho, it's kind of a moving target because you're moving teeth, right? So your bite's always changing. So that's why she comes and sees me too. And I adjust the stops, and then, I'm helping the orthodontist or telling the orthodontist what I would do to close the bite and get things in order. So that's kind of tough. Then I had another patient that was a young boy who's 15 who had bicuspids removed. Like, oh my God. It's in
this day and age?
In this day and age.
You have your bicuspids removed.
Yeah, but
I do too.
Honey, that was 40 years ago, 50 years ago, right?
I already thought, because I did too. Yeah, 40, 50 years ago. So I thought they wouldn't be doing it anymore.
I know. You figure. Ashley from my office and I were talking, and we're like, you know what? That to me is malpractice. But anyway, and I told them what I would do because I'd remake space for those teeth and what have you, or pull things forward. And they are, they have to decide, are they going to go to an orthodontist? I said, I can't co-treat. It's too hard.
Yeah.
It's too hard.
It's too hard.
And it's hard to tell an orthodontist to listen to me, and I'm not an orthodontist.
I know. They don't, like, there's
it's you got to tread very lightly.
You do, because you don't, I mean, there's egos involved, but there's, you know, like, there's so much involved. I don't like co-treating either. I really don't like it, but
once in a while, you just kind of give in.
I know.
Well,
I just need to learn phase 2 now. Okay.
It'll come.
Should we do one more and then
then wrap it up, and then let's get to the conference?
Yes, let's do it. Oh, this is an interesting one. Does TMD cause anxiety and breathing issues? I would argue it's the other way around. Sleep apnea, a breathing issue, can lead you to clench and grind your teeth more at night. You're constantly in a fight or flight state. Grinding the jaw forward opens the airway, but all the clenching and grinding night after night affects the joints and the muscles, and that can lead to TMD.
Wait, what did that question say about depression?
Does TMD cause anxiety and breathing issues? The anxiety is a tricky one because it's like cyclical, right? You're in pain, so you're anxious. It makes you clench and grind more. TMD gets worse. You're in pain. I feel like it's all related. But what are your thoughts?
So I feel like when people come to my office, probably 80% are on some type of anti-anxiety or antidepressive. And I think the pain causes that. And once you get the pain under control, the anxiety lessens. And then I also do an SPG block with the Q-tip. We talked about that before.
We had to do that. Yeah. So I'm doing.
So when you do that, the anxiety lessens because it gets to the sphenopalatine ganglion in your right back behind your nose. And it kind of reboots your computer system. So a lot of my patients, even some of the ladies at the office, they're like, hey, I need an SPG. And I'm like, okay, I've done it before too, for myself.
Maybe I should do it.
But it's really, so it can be hand in hand. But then again, too, you got to make sure there aren't other health issues causing the anxiety, like the breathing and the airway. And we're very airway centric. So we're always looking at the airway, and we're always looking at the positioning, the posturing, and always asking about sleep and nasal breathing. We always want to make sure you're breathing through your nose and your lips are sealed and your tongue in the proper position to the roof of the mouth.
Yeah. Well, I think we can wrap it, but we did want to share that we had a funny thing happen.
What?
So I was in Vegas. My husband surprised me with the trip to Vegas last month, and we saw the Bruno Mars concert. We saw a bunch of my friends from undergrad, and I come back to work, go to work Monday, and I get a text from someone from Dr. Alex's office, Ashley, and she's like, "Were you in Vegas this past weekend?" Because Dr. Alex was too, and she went to the Bruno Mars concert,
which was fabulous.
He was amazing.
I can't believe we were probably like passing each other like this, and not even because we weren't acute, tuned into who we were seeing or whatever. But we had a great time. Bruno Mars was great. We danced the whole concert.
We danced a lot of it too.
We were like, it was amazing.
He was amazing. And I'm just sad we missed each other. So if you ever come to the West Coast or near there, you have to tell me.
Right. Because you might be there.
Yeah.
You know what I mean? Yeah.
Anyways, we just thought that was kind of a funny story. But we will see you all at the next one. We hope you enjoyed this.
We hope you enjoyed, and we are going to get some people to answer some questions at the ICCMO conference.
Yeah.
I'm thinking concert Bruno Mars. Okay. All right. Thank you. Bye-bye.
Bye, everyone.